Welcome to Cardiovascular Innovations 2020. My name is Mazen Abu-Fadel, and I'm an interventional cardiologist at the Oklahoma Heart Hospital and a clinical professor of medicine at the University of Oklahoma. Today we're going to be discussing access site complications. I have nothing to disclose. Avoiding complications is the best strategy. This starts with proper patient selection. Of course, not everybody needs to have a femoral access, and not everybody is appropriate for radial access. Adequate training in transradial and transfemoral techniques are very important, and maintaining a sufficient transfemoral volume is also important so that we don't lose our skills. Understanding the anatomy of both areas and use proven methods and technique to decrease complications is the most important step. There's a long list of complications for both femoral and radial. Of course, femoral has a higher complication rate than radial, but all these complications you see in the list can happen in both axes. We'll start with radial artery complications. Perhaps the most common, the one we see all the time, is radial artery spasm. This stepwise approach helps you get rid of spasm first by using pharmacological agents such as systemic vasodilators and sedation. If that does not work, non-pharmacological mechanism of action, including heating and warming of the forearm to dilate the arteries, also flow-mediated vasodilatation, which can be achieved by a blood pressure cuff inflation for 5 minutes and then deflation, can help dilate the radial artery to remove the sheath. If this fails, deep sedation or general anesthesia may be required at times. And of course, the thing we like to not get to is step 4, which is regional block or surgery. One thing we don't want for sure is a radial artery on a stick or avulsion of the radial artery, as you can see in these pictures. This can be a horrible complication and can cause a lot of radial artery occlusion. Can happen in around 4% of the people getting radial artery access. This can be decreased if you use patent hemostasis, appropriate vasodilators, and appropriate anticoagulation. Majority of these occlusions are usually asymptomatic, and rarely do they need any treatment. Most of the time they resolve on their own. Ultrasound guided access can help with allowing you to see the size of the radial artery and to help you see if there's any disease or dissection from previous procedures in the radial artery to try and avoid. There's an example of a patient who had radial artery access and a patient who has severely calcified disease. One of my dialysis patients that unfortunately had a STEMI intervention in an outside institution and came to me with this picture because of distal embolization from the radial artery and occlusion. Perforations and hematomas are also common. This can happen at the access site or can happen at smaller arteries with the microwire, especially if the microwire is hydrophilic and goes into small branches. In addition, this can happen when advancing larger catheters such as guides and some techniques like the balloon assisted tracking and pigtail tracking may help decrease this complication. One thing I always tell my fellows, if you have problems, you always need to look. If the guides are not going, don't just push, take a small puff and look. And if there's a perforation, you have to do your best to go through the perforation with the smaller wires, advance the guide, let it actually tamponade that perforation, don't leave it alone. Pseudoaneurysms are rare in the radial artery but can happen. This one requires surgery. There are some case reports on newer techniques trying to put another sheath through the area of the pseudoaneurysm and keeping the sheath there for a prolonged period of time to decrease or to stop the blood flow into the pseudoaneurysm and allow it to throw. Now we shift gears. Of course, ideal techniques for femoral access are of utmost importance to try and decrease the complications, using both femoral and fluoroscopic guided landmarks as previously discussed in other talks, and using a micropuncture, looking at the micropuncture wire transition site and making sure the wire of the micropuncture is going in the right direction, and taking a femoral angiogram before upsizing the sheath or giving anticoagulation will help decrease complications. Femoral angiograms are very important. This is an old angiogram that shows after multiple sticks there was a lot of bleeding in the groin area from laceration of small arteries. If you see something like this at the beginning of the case, you just want to hold pressure, don't give anticoagulation, and hopefully you won't have severe. This is an example of a sheath going subintimal and then going back into the true lumen. If you see something like this, you know you don't want to upsize the sheath, you don't want to use closure devices. Maybe just removing the sheath and holding pressure is going to allow you to have no complications and no sequelae. One thing you don't want to do also is take a femoral angiogram when the sheath is against the wall of the artery. This can lead to, which definitely can propagate if you inject too hard all the way up the arteries. To prevent that, you want to put a wire into the sheath and take the angiogram. This is an angiogram taken from a patient who had angioceal closure device, developed limb ischemia, coming from contralateral access and looking, there was complete occlusion of the femoral artery at the site of the angioceal. Thankfully, did not thrombose all the way down. You can see there's some flow still in the profunda and SFA. It was managed conservatively by thrombin aspiration, anticoagulation, and balloon angioplasty with acceptable results. Kept the patient on anticoagulation until this resolved. This can be much more dramatic in cases where the whole femoral artery can thrombose and require surgery from the angioceal thrombin in the. This is a patient who had intervention. After the intervention, developed limb ischemia. He had a perclose closure device. You can see contralateral access because of ischemia after the procedure showed slow flow in the iliac system. The perclose had sutured the artery perfectly. We had to advance wires, and we were able in this case to rupture the suture without rupturing the artery with the use of non-compliant balloons with good results. Other complications, this is an example of popliteal access for SFA intervention. A patient came back with pain. This was managed with a covered stent and resolved. This is another example of a femoral pseudoaneurysm. This can happen due to low arterial stick. Management include either thrombin injection, ultrasound guided compression, or even covered stenting depending on where it is. AV fistula is another complication that can happen. This is a very good example here of why we should listen to the groins before we getting access in the femoral artery, because I bet you listening to this could have indicated there's an AV fistula because there would be a thrill there or a bruit. However, this was not done. Access was obtained on the same side and angiogram showed this AV. The thing that we dread most in femoral access perhaps is high arterial stick above the inferior border of the head of the femur. This, of course, increases the risk of retroperitoneal bleeding, which can be deadly. Retroperitoneal bleeding can be diagnosed clinically if the patient is still in the cath lab and hypotension is there. You can look at the bladder, which I'll show you an example, and the bladder may be shifted to one side. If the patient is already back in the room and they are very stable, they can go to CT scan. If they are unstable, they need to go back to the cath lab, contralateral access obtained, and try to see. This is an example of how the bladder can be shifted because of retroperitoneal. Of course, if you have high access, do not try to put an angioceal. This has been correlated with increased retroperitoneal bleeding because the collagen plug can be attached to the striated muscles of the abdominal wall and you don't have a good seal with angioceal. These are some of the complications you can see in both femoral and radial. Thank you very much for attending the conference and my talk. This is my email for any question.